Hi, my name is Shantran Harris, and I am your instructor for today. Thanks for joining me for our introduction of ICD-10CM neoplasms. If you guys have any questions about this video, continuing education units, upcoming classes, and so forth, you guys can reach me at charris@learnmedcode.com, or you can give me a call at 1-855-263-3669. All right, guys, let's get started. It will be vital for you guys to make sure that you assign the correct ICD-10-CM, which is for the diagnosis, or PCS when you're coding for the procedures, in accordance with the official guidelines for coding and reporting. General coding guidelines for neoplasms. To properly code a neoplasm, it is necessary to determine from the record if the neoplasm is benign, which is non-cancerous, in situ means the cancer is not spreading, malignant means cancerous, or of uncertain histologic behavior, which means the physician has not determined what type of behavior this neoplasm has. The pathology report will have to document this information, or the physician has to document that it's uncertain histologic behavior. This is not an unspecified diagnosis. This diagnosis is used when the physician cannot determine what type of behavior the neoplasm has. If malignant, any secondary site should also be coded. Secondary sites are sometimes referred to as metastatic or metastasis. So if you ever see metastasis tumor or a neoplasm that's metastasis, or you may see that the cancer is referred to metastasis, that's a secondary site, which means the cancer has spread from the first site to the secondary location. Neoplasm alphabetic index should be referenced first when coding for neoplasms. If the histologic term is documented, that term should be referenced before the neoplasm alphabetic index. An example of that would be an adenoma. If you look adenoma up in your ICD-10 book, it's going to refer you back to the neoplasm table. It is important to select the proper column in the table that corresponds, going back to the benign, the in situ, and so forth when they're talking about the type of neoplasm. Then you're going to reference your tabular list. Your tabular list is found in the back of your ICD-10-CM book in most cases, and you're going to go there and you're going to verify your code to make sure you're coding it correctly. Whenever you're coding in your tabular list, or you're verifying your codes in your tabular list, you will receive additional information. You're going to be told whether additional digits are required. You're going to be given more instructions. So it's going to be vital for you guys to make sure you go back to your tabular list. Treatment directed at the malignancy. You would designate the malignancy as the principal diagnosis, which means the first diagnosis listed would be the malignancy. Treatment of secondary site. If treatment is directed towards the secondary site only, the secondary neoplasm is designated as the principal diagnosis, which means you will code the secondary site first. You will have to code the primary site second. You always have to code the primary site whenever coding for a secondary malignancy. The secondary malignancy cannot be coded alone, even if the cancer is resected. So for example, a patient comes in and they have a malignancy located within the lymph nodes. That's a metastatic site or a secondary site. You will need to also code where the primary site was located. So if it was breast cancer, you would code breast cancer second. If the breast cancer was resected and the patient is no longer receiving chemotherapy or treatment for that breast cancer, that would be considered a history of breast cancer. You still would need to code both codes. You would code the secondary location first and the history of breast cancer second. Coding and sequencing of complications for neoplasms. Anemia associated with malignancy. The treatment is only for the anemia. When the treatment is only for the anemia, your first diagnosis listed would be the code for the malignancy, or the principal diagnosis would be the code for the malignancy. The secondary code would be code for the anemia due to neoplastic disease. Anemia associated with chemotherapy, immunotherapy, and radiation therapy. The only treatment in this case is for the anemia. Whenever that happens, you would code for the anemia first, and then you would code an additional code for the neoplasm, and you will need to code for an adverse effect code, which is a T code, okay, which means the patient is having a reaction to something. That's what an adverse effect is, or a side effect to that chemotherapy. That's what an adverse effect is. If the anemia is due to radiotherapy, you're going to code Y84.2. Whenever you're coding for a primary malignancy that was previously excised, you would code from Z85 for personal history of primary malignancy of neoplasm, as long as that neoplasm is no longer receiving treatment. It's excised and the patient is no longer receiving radiotherapy, chemotherapy, or anything along those lines. If cancer has been treated, now it's considered to be a history of. You will code any additional secondary neoplasms whenever they're documented. So if you see any mention of extension, invasion, metastasis to another location, you make sure you code that secondary site. And again, whenever coding the secondary site, you will still need to code the primary site. So if it's excised, if it's resected, and the patient is no longer receiving treatment of that primary site, you will code from the category of Z85. Admissions encounters involving chemotherapy, immunotherapy, and radiation therapy. Episodes of care involve surgical removal of neoplasm, followed by adjunct chemotherapy or radiation treatment during the same episode of care. When that happens, you're going to code the neoplasm first, okay? Patient admitted for encounter solely for administration of chemotherapy, immunotherapy, and radiation therapy. In that case, you will code for the encounter codes first. For anti-neoplastic radiation therapy, you code Z51.0. For anti-neoplastic chemotherapy, you code Z51.11. For anti-neoplastic immunotherapy, you code Z51.12. More than one of these codes may be assigned in any sequence. Okay? When coding for these encounter codes, make sure you code for the malignancy as well. Admissions encounters involving chemotherapy, immunotherapy, and radiation therapy. Episodes of care involve surgical removal of neoplasm, followed by adjunct chemotherapy or radiation treatment during the same episode of care. When that happens, you're going to code the neoplasm first, okay? Patient admitted for encounter solely for administration of chemotherapy, immunotherapy, and radiation therapy. In that case, you will code for the encounter codes first. For anti-neoplastic radiation therapy, you code Z51.0. For anti-neoplastic chemotherapy, you code Z51.11. For anti-neoplastic immunotherapy, you code Z51.12. More than one of these codes may be assigned in any sequence. Okay? When coding for these encounter codes, make sure you code for the malignancy as well. Symptoms, signs, and abnormal findings listed in Chapter 18 associated with neoplasms cannot be used to replace the malignancy as the principal diagnosis, regardless of the number of admissions or encounters for treatment and care of the neoplasms. So if you're feeling tempted and you want to code from Chapter 18 and you want to make that code your principal diagnosis, remember not to do that. One way of remembering what Chapter 18 codes are is to actually look at your tabular list. In the back of your ICD-10CM book, where your tabular list is located, your codes in that section are divided according to the different chapters. So if you're looking at a code and you're tempted to code that as principal diagnosis and then code an additional code that's a malignancy code, don't do it. And you'll know that again by checking the chapter to make sure that you're not coding from that chapter. Malignancy in two or more non-contiguous sites. These tumors may represent different primaries or metastatic disease depending on the site. The provider should be queried as to the status of each tumor so that the correct codes can be assigned. And what that means is, like, if a patient comes in and they have cancer of the pancreas cancer could be located in the body and in the tail of the pancreas. You would need to code for each one. Even though it's the same organ, you need to code for each location of the cancer. Disseminated malignant neoplasm code, which is C80.0, unspecified. This code is used only in those cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. It should not be used in the place of assigning codes for the primary site and all no secondary sites. So if you know where the secondary sites are, or if you know the primary site, you will not use this code C80.0. Again, this is to be used in the cases when the advanced metastatic disease and no known primary are specified. So you don't know the answer to that. You just know the patient has metastatic cancer and primary cancer somewhere. Okay? Malignant neoplasm without specification of site. Malignant primary neoplasm is coded as C80.1. So if the physician is not specific and you do not know the primary location of a cancer, this is when you would use C80.1. This code should rarely be used in an inpatient setting. Sequencing of neoplasm codes. Encounter for treatment of primary malignancy. When a patient comes in, and the reason why they're coming in is for the primary site of malignancy, the primary malignancy site is to be coded first, followed by any metastatic sites. Encounter for treatment of secondary malignancy, which is also known as metastatic location. When an encounter is for primary malignancy with metastasis and treatments directed towards the metastatic location or the metastatic site, which is also known as a secondary site, the metastatic site is designated as the principal diagnosis, and the primary malignancy is coded in addition to that code. Sequencing of neoplasm codes. Malignant neoplasm in a pregnant patient. We are coding for malignant neoplasm in a pregnant patient. You will code for the neoplasm complicating pregnancy first, which is 09A.1. Childbirth and the perineum should be sequenced first. The neoplasm code will be second. Encounter for complication associated with a neoplasm. For management of a complication, the complication code goes first, followed by the code for the neoplasm. Okay, and as you can see, there's a little note here with the exception of anemia, because if a patient is noted as having anemia due to a neoplasm, the neoplasm code will go first and the anemia code will go second. When coding for a complication from surgical procedure for treatment of a neoplasm, you're going to code first the complication of the procedure, and then the neoplasm code will be second. For pathological fracture due to neoplasm, if the focus of the treatment is the fracture, you're going to code for the fracture, which is M84.5. That will be sequenced first. And then you will code a code for the neoplasm. If the focus of the treatment is the neoplasm, and the patient has an associated pathologic fracture, the neoplasm code will be sequenced first, and then a code for the pathologic fracture will be coded second, which is from category M84.5. Current malignancy versus personal history of malignancy. Now, I talked a little bit about this earlier, but I just want to talk about it a little bit more. When a primary malignancy has been excised but further treatment is needed, code the primary malignancy code until treatment has been completed. So you would code it as current. You would code it as a current malignancy. When a primary malignancy has been excised or eradicated, there is no further treatment directed to that site, and there's no evidence of any existing primary malignancy, you would code for the history of malignancy codes, which is category Z85. Malignancy neoplasm associated with transplanted organ. You will need at least 3 codes to describe this diagnosis. First, you will code a transplant complication because a malignancy of a transplanted organ is considered to be a complication. So you will be coding from category TH6. Then you will need an additional code to code for the neoplasm that happens to be malignant associated with the transplanted organ, which is C80.2. And lastly, you will need to make sure you code for the specific location of the malignancy, again, like the breast or the lungs or wherever that malignancy is. Neoplasm-related pain, acute or chronic, you will code from this category G89.3 when the patient comes in and the patient states that the patient is experiencing pain due to a neoplasm. The physician has to document this information. If their encounter is for pain management, you would code for the neoplasm-related pain first, followed by that will be a code for the neoplasm. If the reason for the encounter is for the neoplasm and the patient just so happened to be having neoplasm-related pain, the neoplasm will go first, the pain code will go second. Thanks for watching my presentation. If you have any questions, please feel free to give me a call. We do have upcoming live courses available online, and we also offer self-study courses as well. We offer one-on-one course training and tutoring for people interested in becoming medical coders. Please contact us. We do have a high percentage rate of students passing after taking our courses. So if you have any questions, please contact me at charris@learnmedcode.com. If you would like to look at our website, go to learnmedcode.com, or you can give us a call at 1-855-263-3669. And have a great day.